Welcome to PT Microlessons, fast lessons with big impact. In this lesson, we'll explore the progression of heart disease by following the cardiovascular disease cascade. We'll begin with the major risk factors for endothelial dysfunction and atherosclerosis. From there, we'll examine how plaque formation can lead to coronary artery disease, myocardial ischemia, and acute coronary syndrome. Let's return to our cardiovascular disease cascade. After endothelial dysfunction and atherosclerosis develop, the next stage is coronary artery disease, or CAD. Coronary artery disease occurs when atherosclerotic plaque progressively narrows the coronary arteries, reducing blood flow to the myocardium. As oxygen delivery becomes insufficient to meet myocardial oxygen demand, myocardial ischemia develops. If a plaque ruptures and a thrombus forms, blood flow may become partially or completely blocked, resulting in acute coronary syndrome, including unstable angina, non-STEMI or STEMI. Let's examine each of these conditions and see how they fit into the overall disease cascade. Myocardial ischemia occurs when the heart muscle does not receive enough oxygen to meet its metabolic needs. In many cases, this results from reduced coronary blood flow caused by coronary artery disease. Fortunately, ischemia is initially reversible if adequate blood flow is restored. Patients may experience symptoms such as chest pain or angina, although some episodes can occur without noticeable symptoms. If ischemia becomes prolonged, myocardial cells begin to die, leading to myocardial infarction. Acute coronary syndrome occurs when an atherosclerotic plaque becomes unstable and ruptures. The rupture exposes the plaque contents to circulating blood, triggering platelet activation and thrombus formation. The resulting clot can partially or completely block a coronary artery, dramatically reducing blood flow to the myocardium. Depending on the severity of the obstruction and whether myocardial injury occurs, acute coronary syndrome is classified as unstable angina, non-STEMI, or STEMI. The sooner blood flow is restored, the more heart muscle can be preserved. First, let's start by examining the three types of acute coronary syndrome, beginning with unstable angina. Unstable angina occurs when an atherosclerotic plaque ruptures, and a thrombus partially occludes a coronary artery, producing transient myocardial ischemia without permanent myocardial cell death. As part of the evaluation for acute coronary syndrome, cardiac troponin levels are measured. Troponins are blood biomarkers released into the bloodstream when cardiac muscle cells are damaged. In unstable angina, troponin levels are a key diagnostic finding because myocardial necrosis has not occurred, so they remain normal. You'll see that this finding is critical for distinguishing unstable angina from the other forms of acute coronary syndrome. Lastly, keep in mind that although there is no permanent myocardial injury, unstable angina is still a medical emergency because it often precedes a myocardial infarction and requires immediate evaluation and treatment. Okay, next we will look at the second type of acute coronary syndrome, non-ST elevation myocardial infarction, or non-STEMI. In non-STEMI, prolonged myocardial ischemia results in irreversible cardiac muscle damage, meaning myocardial infarction has occurred. Because myocardial cells are injured and die, troponin levels become elevated. Unlike STEMI, the coronary artery is typically partially occluded, so the EKG does not show ST segment elevation. Instead, the EKG may appear normal or demonstrate ST segment depression or T-wave inversion. Although less dramatic than STEMI on the EKG, non-STEMI is still a medical emergency, requiring prompt diagnosis and treatment to limit further myocardial damage. Let's finish up with STEMI, the third and most severe type of acute coronary syndrome. An ST elevation myocardial infarction, or STEMI, typically occurs when plaque rupture and thrombus formation completely occlude a coronary artery, eliminating blood flow to the portion of myocardium supplied by that vessel. Prolonged ischemia causes irreversible myocardial cell death, so troponin levels are elevated. The EKG shows ST segment elevation in 2 or more contiguous leads, reflecting acute myocardial injury. A STEMI is a life-threatening emergency that requires immediate restoration of coronary blood flow to limit the extent of heart muscle damage. Now let's put everything together by looking at how acute coronary syndrome is diagnosed. Evaluation begins with the patient's history, symptoms, physical examination, and an EKG. The first question is whether ST segment elevation is present. If the answer is yes, the diagnosis is STEMI, indicating an acute coronary artery occlusion. If ST segment elevation is absent, the next step is to evaluate cardiac troponin levels, which indicate whether myocardial cell damage has occurred. Elevated troponins indicate non-STEMI, confirming myocardial infarction despite the absence of ST segment elevation. If troponin levels remain normal, the diagnosis is unstable angina, meaning myocardial ischemia is present without irreversible myocardial injury. In summary, STEMI is identified by ST segment elevation, non-STEMI by elevated troponins without ST segment elevation, and unstable angina by ischemia without ST segment elevation or elevated troponins. So, how can acute coronary syndrome present? ACS can present with a variety of symptoms, but the most common symptom in both men and women is chest pain or chest discomfort. The pain may radiate to the left arm, jaw, neck, or shoulder, and is often accompanied by shortness of breath, diaphoresis, nausea, or vomiting. Although there is considerable overlap in symptom presentation, women are more likely to experience additional or less typical symptoms, such as unusual fatigue, jaw or neck pain, upper back pain, epigastric discomfort, lightheadedness, dizziness, sleep disturbances, or a feeling of anxiety or impending doom. These presentations are also more common in older adults and individuals with diabetes. One contributing factor is that women are more likely to have coronary microvascular disease, or plaque erosion, rather than complete blockage of a major coronary artery, which can influence both symptom presentation and diagnostic findings. The key takeaway is that chest pain remains the most common symptom in both men and women. However, clinicians should maintain a high level of suspicion for acute coronary syndrome, particularly when patients present with atypical symptoms. Regardless of how symptoms present, acute coronary syndrome is a medical emergency requiring immediate evaluation and treatment.
That's it for this PT Microlesson. Like and follow at PT Microlessons for more fast lessons with big impact on physical therapy topics.